So anyway, when I joined David, this is what we were doing at the time. There was no other tomography in the world. We were really the first in the world to do tomography. And this is the machine that was built at the time. And this is a scan that I did on a patient who had brain tumor. There's abnormal blood-brain barrier with conventional isotopes that we were using, not PET tracers. And then in 1973, we got the first CT scan in the world to the University of Pennsylvania. And this is a CT scan that shows that there is contrast enhancement of the lesion. And also you see the rest of the brain, there's edema around the tumor. And it was very clear to us that this machine is going to take over what we were doing with conventional isotopes that we were using at the time. It's a patient with head injury, you see the bleeding inside the brain, but also abnormal blood-brain barrier around it. And of course, we looked at blood volume here, this is RBC, and you see something interesting, but nothing as impressive as CT, of course, abnormal blood-brain barrier. So we knew that this new machine, CT scan, which was introduced by Hansfeld, and he got the Nobel Prize for it, and it was going to take over what we were doing at the time at Penn with conventional isotopes. Next slide, please. Next. So, three of us, David Kuhl, who's mentioned, names I've been mentioned, a neurologist at Penn, sat down one day, this is December 1973, decided that we got to change our direction. We got to get into molecular imaging, and this meeting is about molecular disease, molecular physiology, and this city is very much in line with what's happening in this meeting. Everything is just based on molecules. So we had come up with an agent called deoxyglucose, which I will show you mimics very much like the glucose, but gets stuck in the brain because it cannot be metabolized to CO2 and water as glucose does. So we decided that we should put fluorine-18, which is a PET agent, PET tracer, and see how it works in the brain. And of course, that was the beginning of our activities. And of course, contacted our colleagues in Long Island, next to New York City, and the colleagues were chemists. Of course, they didn't know a lot about medicine. Next slide. Next slide. Okay, so finally, by 1976, this fluorine-18 labeled deoxyglucose was made, and we were able to show that FDG enters the brain through what's called transporters, glucose transporters, and just phosphorylates to FDG6 phosphate, very much like glucose does. But in contrast to glucose that goes through these pathways, FDG remains in the brain. So this was truly God's gift to us, that we could inject this agent and get stuck in the targeted organs. Of course, our first aim was to look at the brain, but of course later, as I will show you, we have gotten into a lot of other areas for glucose metabolism, like cancer and infection and inflammation. So this was the hypothesis that we had, that we have to just prove that this works as we had speculated. Unfortunately, that's what happened. Next slide. Next. Next. Okay, so finally this agent was made in Long Island, and we flew the first dose of this agent. This agent has only 2 hours half-life. Every 2 hours you have half of what you injected to the patient. So we flew by plane, a small plane, and then arrived in Philadelphia, and I did this first brain scans with our machine that we had. Again, nothing very close to what CT was doing because of the spatial resolution that we have, just the details that we have. It's not as good as CT or MRI, but as I will show you, the modern machines can do much better than what we were doing at the time. This is this is August 1976. This is really what I did in 1976. So this became the first FDG scan, which started this revolution that we have today. There's a revolution in medical imaging, and the future is going to be primarily based on PET, not CT, not MRI. Next. 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 So this, of course, just a moment. So this image that I did took me 2 hours, going from the brain down to the proximal femurs. As I will show you, we have modern machines that we can do this in 2 minutes. It took me 2 hours to do this image. But really, I want to show the principle of imaging with FDG, how it works, and how we can look at brain that has got a lot of metabolism, heart muscle has a lot of metabolism. Interestingly, we couldn't fool the kidney, this being as glucose, and everything is excreted. Normally, glucose that is filtered through the glomeruli is picked up by the tubules, but FDG was recognized by the body as not being glucose, so we have some bladder activity. But this really became the total body PET as we know today, because this is really going to be a very important contribution of PET imaging, looking at whole body in 2 minutes for any disease that we're interested in looking at. Next slide. Next. Next. So really, it was a very humble beginning. Honestly, when I showed these images, people were very impressed by what we were doing, because they really weren't seeing behind the scene what really this type of approach is showing us. But fortunately, during the past 40 years, we have been able to show that this is a very, very viable option. So during the past 40 years, with this compound, which really became the molecule of century. They called it molecule of century for 20th century. And we can look at neurologic disorders, such as nervous disorders, Alzheimer's, seizures, and so on. We can look at cancer, infection, inflammation, myocardial variability, atherosclerosis. So one compound started a new specialty. But again, as I will show you, we have gotten 3,000 compounds with PET that we can look at almost every molecular activity in the body. Next slide, please. Next. So really, this is just showing you just the power of approach, looking at molecules rather than the structure, like the CT does. And this is just an image compared to what I showed you, first image that I did with very primitive machines. Nowadays, we have very high resolution machines that allow us to look at the whole brain in a matter of a few minutes and go all the way from vertex down to the base of the skull and just look at various structures. Like this is a normal person, but a patient with Alzheimer's disease will have significant problem in their parietal lobes or significant problems with temporal lobes. So here we're able to look at molecular disease much earlier than we can see with the structural imaging. The structural imaging takes a long time to show abnormality, but molecular evidence goes to show the disease in the very early stages of the disease. Next slide. Because the big thing that we do with PET, next please, is quantification. We can quantify disease activity very precisely. This is my data on normal aging. As you see here, looking at whole brain metabolism, this is metabolic whole brain metabolic rate. And as you see, from age 20, we've gone down. But there are a lot of scattered. So there are people who are in their 20s and want to retire. They belong here. And there are people who are in their 70s and 80s and are up there. So you got to choose your parents correctly to be up here, not down here. So this is really one of the things that we have learned, that there's enormous variability in our metabolic rate as we can measure with this powerful technique looking at quantification. Next slide, please. Next. Next. So, of course, what really has made PET to survive and FDG to survive is cancer. Cancer is metabolically very active for glucose. There's a phenomenon called Warburg. Warburg was a German scientist who showed in the 30s that cancer cells, when they integrate with glucose, they gobble up the glucose. So this was a perfect marriage between FDG and cancer. So this is a patient with breast cancer that is so clearly seen. So what you see on mammography, we cannot tell whether it's malignant or not. But when you do PET, you're able to see that that's cancer, but having the significant uptake of FDG in the tumor. So this really has become a just centerpiece of now practice of oncology all over the world. And again, this has made PET to survive because cancer is much more serious disease than looking at Alzheimer's disease and neurologic disorders. So really, this was a very lucky thing. And actually, we were the first also to look at brain tumors with FDG and continue using it. But brain tumors are not very common disease than lung cancer, like breast cancer, lymphoma, and so forth and so on. Next slide, please. Next. Of course, we can stage the disease. Next, please. So this is a patient with lung cancer, and of course, during the past 20 years, another city in Pennsylvania where I'm from, city of Pittsburgh, developed PET-CT. So we not only have PET, but also superimposed on CT scan. So really, for people who didn't believe on what we were doing with PET, now it's believable by having CT and PET combined. So this patient has got lung cancer that picks up a lot of FDG, but also we can see the lymph node next to it that you will be able to see on PET-CT scan. So really, this is has been a fantastic tool for the oncologists, for the surgeons, and so forth and so on. And this really has kept FDG PET alive. Next slide, please. Next. Because you can see that, of course, we can look at transaxial images. So this is a patient with lymphoma that this is lymphoma, all the lymph nodes that are active throughout the neck, axilla, mediastinum, all the way down to the abdominal lymph nodes. And then after a month of treatment, all these lesions are gone. It takes a long time for CT scan to show that lymph nodes that have been treated and are successfully managed to show that there is a shrinkage of the lymph. But with the PET, within a month, we've seen that all the lymph nodes that we saw here are gone, except for one lymph node there. This actually shows that this patient is not completely cured. So this patient may have recurrence of his lymphoma later on in time. So really, this is just an amazing aspect of molecular imaging, that we are seeing evidence for response so early on, and also predict what's going to happen to patient prognostically with the disease that they have. Next slide, please. Next. Next. So, of course, we are revolutionizing radiation therapy. Radiation therapy is now not only medical oncologists using chemotherapy, is using PET, but also radiation therapists are just without any question that every patient, at least in the United States and parts of the world that have got access to PET-CT, they're using PET in guiding radiation therapy planning and following the patients after radiation therapy. Next slide. Next. Next, please. So this is a patient with lung cancer. If you were to treat a patient based on CT scan, you will radiate the whole area, which will mean that the lung that's next to it is going to get inflamed, and the patient will be disabled because of inflammation in the lung. But when you do the PET-CT scan, you see that half of the lesion is active, the other half is not. And therefore, you are not going to radiate the whole thing. So the complications of radiation therapy are just significantly less when you use PET-CT instead of CT alone in managing these patients. So again, this is a revolution in medicine, that we are making patients not to suffer and get better treatment. Next slide, please. Next. Now, we are, of course, very interested in vascular disease. Number one killer of mankind is atherosclerosis, is not cancer. So really, PET is revolutionizing atherosclerosis detection and seeing response to various treatments. So this is a big area of application of the PET at this time. Next slide, please. Next. So this is a patient with vasculitis. So inflammatory cells pick up FDG. So when you've got vasculitis, there are a lot of inflammatory cells in the aorta and the subclavian arteries. So you can see this beautiful uptake of FDG in major arteries throughout the body. So these patients actually die from vasculitis because you do CT scan, you do MRI scan, you cannot diagnose it. They come with fever of unknown origin. And PET scans shows you such beautiful uptake of FDG in the inflammatory cells in the inflamed arteries, as you see on these images. Next slide, please. Next. Of course, this is atherosclerotic plaques. As you know, atherosclerotic plaques are inflammatory plaques. There are a lot of macrophages in these plaques. And of course, you see it on PET scan alone, especially the arch of the aorta is the site for inflammation. And of course, when you got PET CT, CT, and PET are superimposed. And again, you see this very clearly evidence for atherosclerosis. FDGs is very useful for detecting atherosclerosis. Unfortunately, uptake of FDG in the heart makes it difficult for seeing the coronary arteries. But as I will show you shortly, we have now other tracers that we can use to see coronary artery disease. Next slide, please. Next. But this is a young person, doesn't have any plaques. This is a person 24 years old, doesn't have any inflammatory lesions in the aorta, and a 6-year-old person has significant uptake of FDG in the plaques. So these are the type of images that we are getting now for diagnosing atherosclerosis in the aorta, in the carotid arteries, in the peripheral arteries. Again, a major revolution because this is the most common and most fatal disease of mankind. Just millions of people die every year from atherosclerosis. So being able to detect atherosclerosis, seeing the efficacy of all the drugs, there are a lot of drugs that are being used for getting rid of the atherosclerotic plaques, and monitoring with it, PET FDG is going to be the way to go for seeing what drug is working, what drug is not working. And unfortunately, this is a big problem in medicine. Very shortly after you start the drugs, and just continue medications that are effective and not to continue medications that are not effective. Next slide, please. Next. Now, there's life beyond FDG. We can look at estrogen receptors in patients with breast cancer. It's not only glucose metabolism that we can look at estrogen receptors. We can look at PSMA. Prostate cancer is a big problem in males all over the world, and PSMA is a big part of the cancer cells ingredient. So we have got agent that binds to PSMA and diagnose. This is a big thing right now, especially we have now a specialty called theranostics. Theranostics is that you diagnose as well as treat. This is a big term now for using PET for diagnosis, but also develop drugs. It was mostly based on also radioactive agents that we can treat these patients. This is really applicable to prostate cancer, breast cancer. So this is, of course, also just using the PSMA-based diagnostic agents. Of course, we can look at hypoxia, we can look at fatty fibroblasts. This is a new thing in PET, especially the Germans have been very active in this area, and they have introduced, very much like we did with FDG at Penn, they have become famous because of fatty. This is a big thing, especially for GI tumors. Of course, we can look at amino acids, a variety of amino acids, or slow-growing tumors, and of course, it enables antibody cells. We can just, this CAR T cells are big right now for therapy of hematologic malignancies. We can label CAR T cells to see where they go in the body. We can, of course, look at calcification. This is a big thing, again, for atherosclerosis. I will show you. And of course, as I said, theranostic is really a big term now we have for using PET for diagnosis, and then develop therapeutic agents that we can give with ready labeled therapeutic agents that treat these patients. Next slide, please. Next. Next. So of course, this is a FDG scan here in a patient who has got pancreatic tumor. We don't see as much as we see with FAPI. So FAPI is really becoming useful in other domains. This is the beauty of PET. The sky is the limit. You can label almost every molecule imaginable, and they come up with images that are so fantastic and dramatic. So this is just showing you that FDG is not the end of the world, and though made PET to survive has become very important for many domains, but there are possibilities of using other tracers. So this is, of course, compared to like CT. CT only uses contrast agents, isolated contrast agent. MRI has got gadolinium for contrast agent. So that's just so limited compared to what we can do with PET. Next slide, please. Next. Of course, this is showing you, of course, the molecular aspect of atherosclerosis. So we start with inflammation, and you see it here, the inflammation, atherosclerotic plaque. And then if it goes on, then there's calcification, which is what we see with sodium fluoride. The same thing that you have in your salt, sodium fluoride, there's a PET tracer, and of course, if it goes on for a while, then you see on CT calcification. By the time that you go from here to here, it's about 20 years. So you start in my country, in America, teenagers have atherosclerosis, but you cannot diagnose their atherosclerosis until they're in their 40s. So waiting for 20 years and having irreversible disease that can lead to heart attacks and stroke is waiting too long. This is really what PET is doing. PET is allowing us to diagnose the disease early on and treat the patient right away. So we are going to see positive cases in teenagers, in people in their 20s, by using either FDG or sodium fluoride. That made it becoming very, very interested in sodium fluoride. We're actually doing some very exciting pioneering work at Penn, looking at sodium fluoride for early diagnosis of atherosclerosis. So the molecular classification, which we see in the plaques, is the early evidence that we can see from the outside for atherosclerosis. Especially I can use this in the heart, that we cannot use FDG for it. Next slide, please. Next. So this is, of course, showing you, somebody who is young, 24 years, same person, doesn't have any calcification, and somebody is 69 years old. These are calcification in the coronary arteries that you can see with sodium fluoride. So sodium fluoride is really becoming another very successful tracer, and it's actually very cheap. It's the cheapest isotope we have for PET imaging, and again, atherosclerosis being #1 killer of mankind all over the world is going to use sodium fluoride for early diagnosis of atherosclerosis. And this is going to revolutionize management of the patients with coronary artery disease, carotid artery disease. These days, we have a lot of discussion about dementias, Alzheimer's disease. I truly believe that cerebrovascular disease is going to be a main domain for PET, especially with sodium fluoride, and so that we'll be able to treat patients who have got atherosclerosis, and evidence for dementias with this approach will be, of course, treatable. I don't believe that we can treat Alzheimer's disease. This is a lot of debate is going on, amyloid imaging, and we don't believe that it's going to be successful, but we believe that cerebrovascular disease is going to be the big domain for PET, and therefore treating these patients like the way that we treat patients with coronary artery disease and other atherosclerosis. Next slide, please. Next. Next. Okay, so this is, of course, showing you that with normal aging, we see sodium fluoride working much better than FDG, looking at aorta. This is aortic artery atherosclerosis. This is age. This is the uptake of, again, quantification of PET that allows us to see significant rise in uptake of sodium fluoride in patients who have got high risk for atherosclerosis. FDG is not as sensitive as sodium fluoride. Next slide, please. Next. Of course, PET MRI has become a reality over the past 10 years. So we have a PET machine in the front and MRI in the back. So the patient goes through both, and then you get two sets of images. You get the images with PET, the images of MRI, and then co-register them for applications that are important for MRI. Next slide, please. Next. So these are the domains that PET MRI is going to be useful, namely neurologic disorders, cardiovascular disorders, and musculoskeletal disorders. So really now we have got best of both worlds. We have got a combination of MRI that shows the structure and PET that shows you the molecular aspect of the disease. Next slide, please. Next. This is just beautiful images of MR showing all the details of the structure, and yet PET shows you what is active, what is not active. So this is the beauty of combining the two, that you've got molecular aspect of the brain function, structure aspect of the brain function, and use them very effectively in diagnosis of serious diseases in the brain and treat the patients more effectively by this combination. Next slide, please. Next. This is just showing, next. Yeah, just showing corresponding areas. Next. So we have been very interested, of course, looking at whole body imaging, whole body for diagnosing the disease as a global disease. This is applicable to many disorders, as I will show you. Next slide, please. Next. So there's a new machine, new game in town. This is really something that we at Penn are very interested in, but also Davis, which is another university, and of course, the Chinese have now gotten to this. There's a company that is making this machine. So we can look at the whole body, 2 meters of the body. This is just 2 meters from here to here. So you go inside this machine, within 2 minutes, you get complete images of the entire body, from skull to your toes. So really, this 2-meter machine, and very sophisticated electronics, and so really, this is just amazing. This is the biggest thing right now in medicine, being able to look at the whole body with 1 data acquisition in 2 to 3 minutes. This is just hard to believe, but this is the reality now. We're actually working on it. Davis is working on it, and United Imaging, which is in Shanghai, is making these commercially. Chinese have now 20 of them in China. We have only 2 in America. Next slide, please. Next. Next slide, please. So, of course, this is just this is a 2-minute image. We have that all the way from hands to toes, and we see everything. And of course, these are just spots of the body that we can look at it later. Next slide, please. We're able to get this next slide. Yeah, we're able to give very small amount of dose. See, these are just decreasing the dose of, this is a child that we're looking at the entire body, and you can just see that the images are high quality even though we give small doses. This is a big problem right now with CT and PET, that radiation dose makes it difficult for giving this to pediatrics. So this is going to be revolutionary for pediatrics as well as, of course, with even people who are not child. We don't want to give a lot of radiation. So total body imaging is allowing us to decrease the dose by 40 times. So this is actually a big contribution of its total body images. Next slide, please. Next. So there are a lot of diseases that are systemic in nature. This is really my views about entities that we are going to use this technology more often. You know, like atherosclerosis, a systemic disease. It starts inside the brain all the way down to tibial arteries. We can look at clots. People who have got cancer have a lot of pulmonary embolism. So we not only can look at the lung for lung cancer, we can also look at clots in the tibia arteries, tibial veins, or femoral veins. So this is really going to be important. Systemic vascular disorders like vasculitis. We can look at, of course, musculoskeletal abnormalities, people who have got knee disease, hip disease. So we can look at the body involvement by these musculoskeletal disorders. Of course, hematologic disorders, like patients with lymphoma, patients with multiple myeloma, we can diagnose. Delayed imaging, which we couldn't easily do with conventional PET machines, we can do it because of high sensitivity of these machines. And of course, autoimmune diseases are big these days, and we're able to do this better than total body PET machines than we can with conventional PET machines that have only 25 centimeters per W. Next slide, please. Next. So, my conclusions are very clear. Honestly, this is the greatest revolution in medicine. This is really going to impact of what we do in the bed is going to be significantly more than CT, more than MRI. So we really can just impact patient care by this serious disease and minimize, the suffering of the patients, but also reducing costs. My main aim right now is to make sure that all the countries in the world have access to PET. This is a human right. And in fact, I go around the world and talk to ministers of health to start PET machines. I've been able to do this all over the world because they don't realize that PET is not a luxury. It doesn't belong to the University of Pennsylvania. It doesn't belong to Harvard. It belongs to everywhere because human suffering is the same wherever we are. And also, if anybody thinks that it's costly, they're wrong. If I do a PET scan on a patient who has got nodule in the lung and show that that nodule is not cancer, have saved that patient in mutilating surgery, because the surgeon would have gone in based on CT scan and then put the lesion under the microscope, and the lesion is benign. So really we are minimizing human suffering. At my university, if you come to Penn for lung nodule surgery, you're going to pay $300,000. So really the cost of healthcare is going to substantially be reduced by doing PET scans. We will see efficacy of treatments much, much better. We're going to develop better drugs. SwissKline, which actually is very close to Philadelphia where we are, has 10 PET machines. They're using PET to develop drugs. So all the seeded drugs that are going to where you want it to go, because you cannot do that with conventional chemicals. So really, this is just the greatest revolution in sciences and in medicine. So it is just going to change the world for a better place. And we have been very lucky that our FDG has made PET to survive. But now, as I said, we have 3,000 compounds for looking at sciences as well as just diseases of various kinds, developing better drugs. So this is just fantastic, and I've been very lucky to be involved with this technology right from its early days. Next slide, please. Next. So really, the total body machine, of course, is really adding a major dimension to what we can do with PET scan, looking at whole body for a variety of change. And this is really going to change the whole paradigm of medicine understanding, how disease works. So we will really just have a better way of looking at the disease at the molecular level with the multiple traces that have been developed right and left all over the world. Next slide, please. Next. So, in a way, we compare what we did with FDG to what Röntgen did with X-ray. This is Röntgen's wife's hand in 1895. This was a great beginning for showing the importance of imaging as a non-invasive technique to look at the disease activity. But what he did, just to pack the entire body into one film. What we have done, of course, with tomographic images, we can just see much more details, and of course, looking at molecular level, and this is really a much, much better way to look at disease activity. Next slide, please. Next. Of course, this is Dalai Lama, who's visited me. I'm here, and he had learned about PET, so he came all the way from Nepal to come and visit us, and I'm showing him what I've done with PET scans, so you can see how far we have gone. You know, we even have people, spiritual people like Dalai Lama. I was interested, of course, we were doing a lot of work in the brain, looking at the spirituality and meditation and all that, and that was major motivation for Dalai Lama to come and talk to us. So really, this is a great revolution, and I'm just very lucky to have been part of it, especially representing this part of the world. Starting a very humble beginning in Tabriz and being lucky to be at a place like Penn and working very hard. I was just telling the students that hard work is my #1 just message to young people. You know, if it wasn't for my hard work, I probably wouldn't be standing here giving them this talk. So really, hard work is a very important part of my message, and I have a lot of students, both within the in UPenn, but also have students all over the world, and it's just being an academician, taking care of patients, teaching, and doing research that leads to inventions like we have with PET. It's very, very gratifying, and I'm just very lucky that I'm making my father's soul happy that his son is doing something that is helping other people while he suffered 6 months before he died. And so that's also given me a lot of satisfaction that my work is also just making my father's soul happy. Thank you very much for really listening to my talk.